So Majid presented a very difficult topic, and the bottom line of Majid talk is you cannot treat plasma cell leukemia. So we'll move on to something that's very interesting. So what is the role of BCMA therapy in patients with relapsed refractory myeloma? It's very unfortunate when you see, a publication published in October of 2025, labeled the Saudi myeloma guidelines, and you look at it today, and it has to be updated because the second line in that paper doesn't actually apply to today. So if you look at the topic today, we wanted to really explain to you that PCMA should actually come earlier. This is a satellite symposium funded by our colleagues at GSK who manufactured belantamab mavedotin. But over the last, literally 10 years, the landscape of myeloma have changed significantly from the advent of, daratumumab to isatuximab, and then belantamab, came initially in 2019. Initial publication took off the market, was withdrawn from the market because of, the dosing was not, optimized, and now it's back again with the addition of also teclistamab and talquetamab and linvoseltamab and CAR-T and elranatamab. So this guideline is outdated, and I would recommend that Dr. Ayman start working on the next iteration of this guideline, because the second line in most of our patients now should be three options. Option number one is they either go for a CAR-T or they should go for daratumumab with teclistamab as a second line, or if they're actually in the category where they cannot have access to the initial two, then maybe belantamab-based combination should be an option. And I'll show you that, compared to whatever conventional triple therapy you have as second line, these three options, outtrumps these things in terms of overall survival. So CAR-T has been covered very well by Dr. Saleh, so we will not, spend too much time. But we have ide-cel, which has never left the USA, and then the cilta-cel that's available in Saudi, and these are the data you've seen earlier. The outcome of the CARTITUDE-4 is quite excellent, but it's not actually the best in the world. But it's still, it's a one-point therapy. People on average they become disease free for a couple of years. They will not require any other therapies if they survive the CAR-T without cytopenia or needing transfusion support. So now, what is the third option? Belantamab as an anti-BCMA antibody drug conjugate is available in the market to be used from 1 to 3 lines of therapy. It comes in two combination. So in those who are LIN refractory, then belantamab Velcade Dex is an option, which is probably have a better efficacy and safety than any other combination from the conventional, three drug regimen we used. We used to give Dara KD as our famous second line. In the DREAM-8, belantamab Pomdex has been also investigated and examined against, pomalidomide Velcade Dex. So DREAM-7 was actually established on the basis of the DREAM-1, DREAM-2 studies in the 2015-16 time. So it's belantamab Velcade Dex. So those people are actually LIN refractory from the beginning. The comparator is actually Dara VD. So it's actually a very nice control arm, and this is the first time we see a study, really examining a good drug versus conventional therapy that we actually can use in the second line setting. And you can see the dosing is way much different than the initial study. So now it's actually 2.5 milligram. In the DREAM-8, it's actually 1.9 milligram. And in those people, the treatment is given literally every 3 weeks to even every 4 weeks from the beginning of the study. The initial dosing was actually 2.5 milligram weekly for 3 weeks. So it's, that's why it used to be toxic. And then you can stop the Velcade Dex at one point from cycle 9 and continue on belantamab. So what we see from this study is if you give somebody Dara VD, then you're giving them an inferior outcome compared if you give them belantamab Velcade Dex. So their median PFS is much better at 40 months follow-up. So it's actually a very effective therapy where the median overall survival was not reached in the intervention arm compared to the control arm. So that's a very valid option. Now, what are the baseline characteristics of those people, or what are the post-protocol therapy? It's not uncommon to see, the post-protocol therapy not being the most effective therapy in myeloma. And maybe some of the safety, maybe some of the overall survival signal is driven from the subsequent lines of therapy they have received. But it's very important to know that they mostly received a data-based combination in their subsequent lines of therapy, so it's considered appropriate. Not so many of those people received a T-cell engager as a subsequent lines of therapy in the control arm. So the benefit was actually very clear even in the PFS number 2. So whatever second line of therapy they received, you can see that still the intervention arm is doing much better compared to the control arm, with about 49% risk reduction in progression over the study period. So what therapies they received? They mostly received darapomdex or isopomdex. So the good majority of those people received daratumumab-based combination. These combination were actually done in about 53%. Some of those people, they had received pomalidomide-based combination. A good chunk they received carfilzomib, and so on and so forth. Those who received an anti-CD38, the most common companion is pomalidomide in the about 1/4 of the patients. Some of those people, in about 8 patients out of 46, they have received daratumumab monotherapy, which is not a very common regimen we use in the subsequent lines of therapy. Do they use bispecifics? About 10 patients throughout the whole study, they received the subsequent T-cell engagers, but in small numbers, some of those received cevostamab, pomdex, teclistamab, or talquetamab. So about only 10 patients, and the outcome of those people was actually much better than the outcome of those who did not receive a T-cell engager in the post-protocol therapy in the control arm. So one of the important facts in myeloma is those who are len refractory, they do very poor, regardless of their line of therapy. So in this study, those who are len refractory, they were about 50 to 60% of the study population in the DREAM7. They have outperformed the DARA-VD arm in the control arm. So the median PFS or the median PFS is about 25 months compared to about 8 months in the DARA-VD. So it's definitely a much better therapy, especially in those len refractory 1 to 3 lines of therapy. Their overall survival is much higher compared to DVD, so about 85% versus 60%. So it's a great option to be considered. And the MRD negativity rate was about 25% compared to only 5%. And we know that MRD negativity rate is actually much lower in the relapse setting. So the numbers I quoted in the initial talk was in the initial first line of therapy, where you can see 50, 60, 70, even 100%. But in the relapse refractory setting, this number goes down by half. And then the duration of response, is certainly much better. So duration of response is those who achieve the CR, how long do they stay in PFS, and the median has not been reached in the first intervention arm compared to the DARA-VD arm. So DREAM8 is similar, but a tiny bit less efficacious combination, because those populations are actually a tiny bit different. They're mostly, they continue to say 1 to 3 lines of therapy, but they're mostly beyond 2 lines of therapy. The backbone is pomalidomide dex-based compared to, POM, Velcade, dex in the control arm. And again, their primary endpoint is PFS, and their key secondary endpoint is overall survival and MRD negativity. So mostly those people are, again, about 50% or more, they're actually beyond 2 lines of therapy. They have received lenalidomide in about 100% of the time. So those are certainly len refractory in all comers. Their prior exposure to anti-CD38 is not very high. It's about 20-25%. So is it an effective therapy for those patients? If in the second line, it's super effective compared to the Velcade Pomdex, which is a reasonable second line therapy. So the median PFS in the extended follow-up study is about 30 months, which is something you don't actually see in the second relapse third line setting, compared to only 1 year, which is very expected. But this is what we see in third line therapy. And the PFS has been maintained across all arms, and almost all groups have actually benefited quite a bit from the combination of an anti-BCMA antibody drug conjugate. So forget everything I told you, because I think we know that belantamab is effective. Any anti-BCMA is more than conventional therapy. Now, how can we overcome the very bad hype of belantamab, which is the ocular toxicity? So the mavedotin is actually quite toxic to the cornea, and we've seen this mostly in the belantamab, but we have not seen this with other mavedotin because of the MMA is a tiny bit different in the mavedotin with belantamab than the one you see with brentuximab or any other antibody drug conjugate. So in the study, about 90% they had an eye side effect. So this is something we have to know from the beginning. And those who come to the study with risk factors to any eye adverse events, they will probably have a high probability to develop this. But if you actually look at the majority of these eye adverse events, they're mostly blurry vision and dry eyes. So really serious eye manifestation is not very common. Blindness did not happen in the study. So nobody's going to get blind from this drug, but their best corrected visual acuity, drops with time. And this is why we should really look closely to those people. So in the label, they have to see an optometrist, prior to every visit. And then, based on certain numbers, you can actually either stop the drug and space it out, or you can even go down on the dosing. And with this effective, strategy, and this is why the FDA went back and reapproved the drug, after the REMS, program they have created. So the ultimately dose reduction happened in about 60% in the study population. Discontinuation only happened in about 9% if you actually accurately follow those people. And the follow-up is actually very easy. So it's a certain number, you have to look it up, and if they reach this number, then either you do dose reduction or you do discontinuation, and then in a couple of weeks you go back and examine them again. And the majority of those people, their eye side effect comes back to normal. So now, what is the expected timing? Don't expect this to happen quickly. So I have currently 6 patients on belantamab from their compassionate use, and it's very early to see these side effects, except until you reach 11 weeks. So 11, 16 weeks is when most of these side effects happens. And if those who develop blurry vision, you can sometimes expect correction without holding therapy. But in those you hold therapy, in about 9 weeks, all of these side effects disappear completely in those people. So reduction in best corrected visual acuity was reported in about 35% of the patients. So now, does it truly affect if you continue or discontinue therapy or delay therapy? Does this affect the effectiveness of the drug? The correct answer is no. It actually hasn't been very detrimental to the effect of this drug. But what's interesting here is most of those people. So here the percentage of people who developed 20/50 vision or worse, the number goes down because the spacing of the drug continues to go up. So the initial study, according to protocol, is every 3 weeks in the DREAM7 or every 4 weeks with PALM combination. So you start every 3 weeks, and in the majority of patients, at one point it becomes every 9 weeks, every 12 weeks. So the drug continues to be over a very long period of time, but the response or the median, the depth of response remains the same. And this has been the case in both, the DREAM7 or the DREAM8. So now, in those who had extended, dose delay, what happened to them? So those who started with less than PR, which is about 55%, even after discontinuation, 94% they had either they maintained PR or they actually had a deepening of response. So we know that these are a very effective drug. The utilization of maximum tolerated dose is not the right strategy. It's probably a small amount of drug is needed to suppress the BCMA. And this is the same thing with the DREAM8. I think the take-home message from the DREAM7 and 8 ophthalmology examination is, dose modification is very important. The amount of people who had remained with response even after more than 9 weeks of delay is 92 in the DREAM7 and 94 in the DREAM8. So those about more than 90%, they continue to have the same, depth of response despite even more than 9 weeks of discontinuation. But keep in mind the number is not very high, but it's about 100 patients. The other take-home message is if you look at the clinical trials reporting, so the CTCA grading, all of these side effects or these blurry vision or dry eye, they're more or less grade 1 toxicity. They're not actually grade 3 or 4, and that's in the majority of the patient, more than 90%. So and in those who started the study, they get initially reading assessment and ability to driving assessment. Even with the side effects, 97% of the time it did not affect their reading ability, and 92% of the time it did not affect their driving ability. So it's an effective drug in my opinion, but we just have to be very careful with how you manage it. Again, we're back to 3 options. Second line, CAR T is probably the best. If people can afford going to CAR T, not necessarily first relapse, but probably best timing is second relapse to compensate for the expected secondary toxicity and neurotoxicity that happens from CAR T. Probably anti-BCMA bispecific plus daratumumab is a very more appealing drug with some infection risk, but a tiny bit more safety profile. Belantamab can come to a small proportion of patients who are probably at a high risk of infections, because with this drug, risk of infection has not been very high. With that, I think we'll conclude because the bispecific talk has been covered. Thank you very much.